Hi, my name is Nida Qadir. I'm one of the pulmonary faculty here at UCLA. I'm very excited for you all to learn more about this next topic, which is ICU recovery. We had the pleasure of starting a multidisciplinary ICU recovery clinic here in February of 2020, so just in time to have to adapt to COVID. I worked together with Dr. Kristin Schwab, who was a fellow at the time, to get this clinic started. So any of you listening who are fellows, think big. She joined our faculty in July, and this clinic's been an incredibly rewarding experience. Dr. Schwab's been the life force behind the clinic, so I am going to let her take it from here.
All right. Hi, everyone. I'm Dr. Schwab. It's nice to be here, and thank you all for the opportunity to speak at this conference. So in terms of what we're going to talk about today, first we're going to give a little bit of background about ICU survivorship and specifically post-intensive care syndrome. We're then going to talk about post-ICU clinics in general. And then we'll, after that, move on to our UCLA experience in particular, specifically going into what's been going on in our clinic in the setting of the COVID pandemic. And then we'll leave time at the end for some questions and comments. So as a bit of background, so in terms of ICU survivorship, we do know that there's an increasing number of patients who survive critical illness every year. This is a graph over time where you can see that hospital mortality, which is that black line, has decreased over time. And this is actually despite the fact that the average age, which is that blue line, as well as the severity of illness, which is that red line, have both increased over time. In terms of survivorship for COVID-19 patients, and so we're of course still figuring out a lot about what the mortality is, but we do know that it's relatively high, and there are significant variations both kind of across the country as well as the world, significant variations as well in terms of centers, but we do know that with the number of previously healthy patients who are now surviving and recovering from COVID, there's an increased need for our clinic. And so, of course, we feel great when we discharge an ICU patient to home, but there is a cost to this survivorship. There's significant medical and psychological sequelae, which I'll go into in future slides. There's also significant financial sequelae for the patients. I'll draw your attention to this second point, which is that 44% of previously employed ARDS survivors are jobless at 12 months. And so even a year after their hospital stay, almost half of patients are unable to return to work. This bottom quote by Mark Moss was actually given or taken from when he spoke last year at the CTS meeting. And what he said, I really love and just wanted to echo again because it's so relevant now also in regards to our talk, especially that improving outcomes after critical illness is a mandate to the critical care community. So I also wanted to mention this one quote from one survivor. This is actually from the Facebook ARDS support group page, and I think it highlights kind of in detail kind of what these patients often kind of deal with. I'm actually going to move my video just so you guys can kind of see the quote. But so she said, "I'm in desperate need of some advice. I'm a year post-cardiogenic shock, ARDS, MRSA pneumonia, kidney failure, sepsis, among a slew of other complications, all from a ruptured appendix. I'm physically getting stronger every day, but the mental aspect is literally killing me. I'm an accountant, and at this point I cannot return with my current impairments. I'm 49 years old and feel like my life is over. I have been researching post-sepsis syndrome, but my PCP doesn't know about it and thinks that it's all PTSD. My hands are tired of Googling and getting nowhere on top of reading something and not being able to retain it. I'm so lost and not sure who to turn to for help or what kind of doctor I would see for this." And so this segues quite well into post-intensive care syndrome. So there's actually a branch of this that's post-intensive care syndrome for the family member, which I won't speak about in this talk. I want to focus on what the patient often experiences. And so post-intensive care syndrome is defined as a new impairment in one of the following three arms, the arms being mental health with anxiety, depression, and PTSD being kind of the most common diagnoses leading to impairment. There's also the cognitive impairment arm where we see people have issues with executive function, memory, and attention. hypertension, and then there's also, of course, the physical impairment, and that being both pulmonary and neuromuscular levels of impairment. And so any one of these three arms qualifies someone as having post-intensive care syndrome, and you can imagine that this leads to a significantly decreased quality of life for the patients. So now focusing on the cognitive dysfunction arm of PICS, this was really highlighted in this 2013 brain ICU study. The authors looked at 821 MICU or SICU patients who had been hospitalized with respiratory failure or shock. And they assessed these patients with this assessment called R-bands, and they did this at 3 months and 12 months. And I think what's notable in terms of the patients they enrolled was that only 6% of them had any cognitive impairment at baseline. And so previously these were high-functioning individuals. And what they found was that the mean global cognition score, where 100 is normal, was actually 79 at 3 months and 80 at 12 months. This is the graphs for all three of the different age groups they looked at, so less than 49, 50 to 64, and greater than 65 years. And you can see that there was a significant decrease compared to normal, which is that green horizontal line for all of these three age groups. And that red dot kind of at the greater than 65-year arm is for what we see in terms of R-bands for people with mild cognitive impairment. You can see that these ICU survivors really kind of have levels approaching that. What they also found was that a longer duration of delirium was independently associated with worse global cognition. And so on this x-axis is the number of days with delirium, and you can see that as the number of days increases, the R-bands at 12 months decreased. I'll also point out that this suggests that there is a possible intervention or an area that we can really focus on in the hospital to help these people moving forward out of the hospital by really focusing on ways to decrease hospital delirium. So I'm going to talk or pause at this point for a question just to get you all kind of thinking. And I'm wondering, I want you all to kind of think about approximately what fraction of ICU survivors will suffer from PICS at 3 months. So the answer actually is that 2/3 of ICU survivors will suffer from PICS at 3 months. And this comes from this study that looked at ICU survivors in 5 United States ICUs. And what they found was that survivors at 3 months had one or more PICS problems in 64% of those survivors, and then at 12 months, 56% had one or more PICS problems. And then, as you can see from these overlapping Venn diagrams, there were co-occurring problems in 25% of patients at 3 months and 21% of patients at 12 months. So a significant majority of patients will have an impairment in one of these three realms at 3 months as well as at 12 months. In terms of post-ICU mortality, readmissions, and costs, what we know is that in the 5 years after an ICU stay, post-ICU patients will have higher mortality, more ED visits, more hospital admissions, and higher medical costs. And so this is a graph taken from a study in Scotland where what you can see is that the proportion of people surviving from 0 years to 5 years after that ICU stay is lower in the ICU cohort, which is that bottom black line, as compared to a hospital cohort, which is that middle line, as well as compared to the general population, which is that highest line. This graph shows hospital costs, again, compared to that index admission, which is that zero vertical line that you see. And what you can see is that for both emergency room visits as well as all admissions, which is the higher kind of lighter gray line, there's significantly higher costs in those 5 years after an ICU stay. And I put an arrow here at this 1 year point just to highlight that that first year in particular is a particularly vulnerable time for these patients where there's significant healthcare utilization, again suggesting that there's certainly a way to intervene at that time that could really help these patients. So I'm going to move on now in talking about post-ICU clinics and the outcomes we know about these post-ICU clinics. So what's pretty interesting off the bat is that post-ICU clinics are much more widely adopted outside of the US. And so I found this data suggesting that in 2006, there were about 80 post-ICU clinics in the United Kingdom. And so of all the ICUs in the UK, about 30% of them actually had a associated post-ICU clinic. In 2019, this is the most updated data I could find, there's about 16 post-ICU clinics that are actually registered here in the United States. And so even 13 years later, we have significantly fewer post-ICU clinics here in the US. And the UK's guidelines actually do recommend that survivors follow up in a post-ICU clinic. The guidelines state that adults in critical care for more than 4 days should have a review by a healthcare professional 2 to 3 months after leaving critical care to talk about their recovery and any problems they may have. And looking at the US guidelines, at least the most recent guidelines I show don't have this recommendation, at least not yet. So now this is our second question, which is, have post-ICU clinics been shown to improve patient-centered outcomes such as health-related quality of life, depression, or mobility? So the answer actually is no. I'm going to go into this now here, which was surprising, I think, for us to find out, and also I think surprising perhaps for you guys given our passion and enthusiasm for post-ICU clinics. And so this was the practical study. This study was the first study to kind of look at post-ICU clinics and these patient-centered outcomes, and it was published in the BMJ in 2009. It was a multi-center randomized control trial where they looked at this nurse-led follow-up program, and they compared this to standard care. And in this follow-up program, there was a rehabilitation program that all patients received on discharge, and then there was a 3-month and a 9-month critical care follow-up appointment. And what they found was that there was actually no difference in health-related quality of life at 12 months, which was their primary outcome, and which is what you can see here in this table below. When looking at the health-related quality of life, or the SF-36 score at 12 months, you can see that those p-values are not statistically significant for the intervention versus the standard care groups. They also looked at a variety of other secondary outcomes, and for these they also found no statistically significant difference in health-related quality of life at 6 months. They also didn't see any differences in PTSD, anxiety, depression, return to work, satisfaction, or quality scores at 12 months. Now, there have been a few other randomized control trials that have actually also had led to similar conclusions. There was this SMOOTH trial that was published in JAMA in 2016. They looked at follow-up with nurse care managers, and then there's also this REVIVE and RECOVER trial that looked at more kind of rehabilitation outcomes. And so each of these looked at a single intervention, but what they found was that there was really no differences in health-related quality of life, mobility, depression, anxiety, or PTSD with any of these interventions. This is a systematic review that was published back in 2014, and the conclusion here, just to highlight, is that interventions which have substantial effects in post-ICU patients are rare. And so this kind of just summarizes all of the studies that have been done up until 2014, where they really didn't see many that had a significant difference in terms of patient-centered outcomes. So of course, I'm sure you're all wondering then, based on that data, why have a post-ICU clinic? And in the slides that follow, I'm hoping that I'll be able to kind of convince you guys of the reasons why even though the studies to date have not shown any kind of statistically significant difference with these post-ICU clinics, that they still are the right thing to do, I believe. First off, it's likely that they may not have studied the correct intervention, and this is largely because PICS and post-ICU clinics are really still very novel concepts, and so you can imagine that the first iteration of the clinic is unlikely to be the ideal iteration. This picture on the right is just highlighting the recommended resuscitation method back in the 1850s, and that was where they actually recommended turning someone on their side and using this as the optimal way to resuscitate someone during a cardiac arrest. And so as you can see, this first iteration back in the 1850s is nowhere close to what we recommend now for cardiac arrest or ACLS guidelines. So similarly, with post-ICU clinics, it's possible and likely that we're going to be able to continue and improve our ability to help the patients. The second point, I think, also is important, where it's possible that these studies didn't actually evaluate the correct outcome. So here's another study that was recently published in 2019, and they looked at an outcome of readmissions. And so what this was a randomized control trial where they compared a structured follow-up program. And this follow-up program encompassed first an inpatient visit while the patient was still in the hospital before discharge. They also had a 24/7 phone number for patients to call after they were discharged, as well as a post-ICU clinic visit. And they compared this program to usual care. And what they found was that their primary outcome, which was readmission within 30 days, was 14% in the ICU recovery group and 21% in the usual care group. And so while this wasn't statistically significant, there was a trend toward an improvement in decreased readmissions in the recovery group, in the intervention group. And then they also looked at this composite outcome of death or readmission within 30 days. And here they did actually find a statistically significant difference in their intervention group compared to in their usual care group. This was another study recently published that looked at sepsis survivors, and they evaluated whether these survivors received these various care elements. There was med recon on discharge. There was also screening for functional or mental health impairments, such as the ones that are encompassed in PICS. There was also this element of monitoring them with a post-discharge follow-up appointment, and then there was also this element of goals of care assessment. And what they found was of the 189 survivors they looked at, 35% were readmitted and 17% had died, which are both pretty strikingly high numbers. But then what they found was that receipt of 2 or more of these elements was associated with a lower odds of 90-day mortality or readmission. And you can see that that adjusted odds ratio of 0.26 is extremely impressive in terms of showing a difference between these two groups. Another point in terms of a benefit of a post-ICU clinic is the intangible benefits that you might not be able to pick up in a study. This is from an article that the Vanderbilt group put out last year. But one benefit of a post-ICU clinic, of course, is to increase awareness and recognition of PICS. This kind of segues back into our point from that patient quote when we started, where PCPs are often dismissive of the possibility that critical illness could result in persistent sequelae, where knowledge about newly acquired conditions and their future trajectories can be scarce when an intensivist is not involved in that post-discharge follow-up. These clinics can also improve continuity, intervening on everything from missed vaccinations, also making sure that all the rehab orders and referrals that are needed have been placed, also picking up on peripherally inserted central catheters that are still in place, or IVC filters that are still in place, which is something that we found in our post-ICU clinic. Also making sure that all the medications that the patient was discharged with actually are still necessary in the long-term outpatient setting, where we've found many PPIs or antipsychotics that have been left on the discharge medication list that people likely do not need long-term, and we've been able to discontinue. There's also, of course, the benefit of providing feedback to ICU providers by having this post-ICU clinic. There's the benefit or the opportunity to do long-term outcomes research. There's also the opportunity to improve your goals of care discussions with people in the hospital by having a greater knowledge and a firsthand knowledge, really, of what people experience in the months and years after survival. And then there's also, of course, this benefit in terms of quality improvement for the ICU stay and the ICU care that the providers are giving inpatients. These are some of the ways that we've kind of been able to feed back to our inpatient team through our post-ICU clinic here at UCLA. We have modified the proning methods that we've used because we started noticing some facial pressure sores in the outpatient setting. We've also updated the guidelines to recommend placing arterial lines on the non-dominant hand because we started seeing significant neuropathy that was debilitating patients outpatients. We've also really increased our vigilance for delirium on the inpatient side by realizing that there's patients we see outpatient who recollect significant and alarming rates of delirium, hallucinations, and just confusion in general. And when we look back at what the CAM-ICU scores were charted as inpatient, they actually hadn't been recognized as having delirium when they were in the hospital. And then we've also increased the use of Zoom conferencing for a lot of our COVID patients, just by talking with them in the post-ICU clinic and realizing that the conferencing with their families was one of the most useful parts for them in their recovery. We've also found that our post-ICU clinic has increased the number of referrals within our own hospital system, and so we've been able to connect patients with PCPs as well as other specialists within the UCLA system, thereby increasing the number of patients we're able to follow and see outpatients. We've also seen significantly high rates of satisfaction when we talk with our patients. It seems like something that they're really loving when they see us in clinic, and so the post-ICU clinic has been very helpful for them. And then lastly, we've really seen the benefit of our post-ICU clinic for providers in the hospital. We've been able to feedback and talk with the inpatient nurses to tell them about how great their patient who they took care of 2 weeks ago is doing now. And it's really helped, I think, morale in the hospital to hear about how people are doing outside of the hospital. So here's one story to kind of give you guys a more concrete example of what we do in our clinic. And so this was Mr. MS. He was a 53-year-old male with hypertension. He was admitted with COVID and severe ARDS, actually required intubation for 10 days. He was ultimately discharged on April 10th, and then he was seen in our post-ICU clinic on May 21st. And what we noted when we saw him in clinic was that he had ongoing dyspnea as well as atelectasis that we picked up on physical exam. And so for this, we were able to give him the lung reconditioning exercises that we give to many of our COVID survivors when we see them in clinic. Our respiratory therapist, Joe, was also able to give him a TheraPep device to help him improve his atelectasis and improve this airway expansion for him. We also followed up on this new diagnosis of diabetes that we had picked up on in the hospital, and we connected him with a dietitian, and actually pretty remarkably his A1C in these 3 months following has fallen with the interventions from the dietitian as well as an endocrinologist from 9.5 to 6.3. We also noted this groin mass that was picked up, I think, in the setting of significant weight loss while he was hospitalized. So we ordered an ultrasound to further characterize this. It actually came back showing concern for liposarcoma, and so we were able to arrange an MRI to further characterize it, and then an appointment with an orthopedic oncologist where they're actually planning to remove this, given that it does look like cancer. He also endorsed significant neuropathy in that right wrist, which is where he had a previous A-line, and so we were able with our occupational therapist to help him in terms of treatment for this. And then we also, as I had mentioned earlier, updated our guidelines to recommend preferential placement in the non-dominant hands. We noted these facial pressure sores from the proning, and so we fed this back to our inpatient team, our inpatient proning team, and then we also changed the ointment prescription to further enhance wound healing, and then referred him to dermatology for ongoing care of this, given that it was in a pretty apparent position on his face. During our PIC screen, we noted that he had significant insomnia with nightmares and flashbacks, and so we referred him for PTSD and insomnia counseling. And then we also noted that he still had significant limitation from a functional mobility standpoint, and so for this, we provided him with a 6-month handicap placard and have been able to keep checking in with him from a social work perspective to make sure that he's doing okay financially. Here are some of the testimonials from some of our patients. I won't read all of these, but suffice it to say that we've really seen tremendous gratitude from our patients, and it seems like they have derived significant benefit from being part of our clinic. So next I'm going to segue, and that kind of segues us well into our UCLA experience. And I specifically want to highlight what we've seen now that a significant proportion of our post-ICU patients are COVID-19 survivors. And so our clinic is a multidisciplinary clinic where the patient meets with a respiratory therapist, an occupational therapist, a physical therapist, a social worker, a pharmacist, and an intensivist. And so we really try to address all these different realms to help the patient in their multifaceted recovery. In terms of our clinic flow, and so before the patient comes to our clinic, there's a pre-clinic telephone call. This is done by our respiratory therapist discharge navigator as part of our U-Breathe program. You'll actually hear from the U-Breathe team and Matthew and Joe in a future talk here, but that has been tremendous in terms of connecting the patients with our clinic and getting them familiar with what to expect during their clinic visits. Oftentimes for the COVID patients, we've also had an MD video visit ahead of time just to check in on them and further kind of streamline this visit when we see them in clinic. When they actually come to the clinic, they first fill out questionnaires, and the questionnaires they're filling out are to screen for the mental health arm of PICS. We then vital them and room them, and then once they're brought back to a room, the patient stays in the room and our multidisciplinary team rotates in to do each of their assessments. And so our respiratory therapist, Joe, performs spirometry and a 6-minute walk on our patients. Our physical therapist then goes in to do a more complete physical therapy assessment. Our occupational therapist does an OT assessment and then also performs our MOCA, which is our cognitive screen for PICS. We then have a social worker and a pharmacist who can meet with the patient on an as needed basis, and then we as the MD come in finally to kind of assess everything that's been talked about from the rest of the multidisciplinary team's perspective, as well as do our own doctor medical assessments. In terms of this assessment that we do, so we're, of course, reviewing their hospital and post-hospital course, looking at kind of symptoms they're still having, and specifically honing in on those PICS screen questions to assess for any PICS conditions. We do a standardized dyspnea assessment. We specifically look at those medications to see if there's any medications that can be discontinued. We assess whether they are able to return to work and how they're doing from a financial standpoint. We also circle back on kind of all of the healthcare maintenance and make any referrals that we think are necessary to further evaluate various conditions. And then there's a significant patient education component where we talk with them about PICS and ICU recovery and what they can expect. And we also talk about the results of everything that's come back from their clinic assessment. And so we talk about what their spirometry was and how that compares to someone else of their age, what their 6-minute walk test was and whether that was normal or abnormal, and so on and so forth. And so we're able to give them a lot of information that's really tailored to their specific recovery. Now, when we see our COVID survivors, there's a little bit of adaptations that we make, though actually not that much. I just highlighted here that we don't do spirometry on these patients just because of the aerosolization risk, but the rest of the assessment is actually not very different from our assessment for any other post-ICU survivor. In terms of what we do from a physician standpoint when we're in the room with the COVID survivors, our symptom screen is a little more tailored just to what we've been seeing come up time and time again with some of these COVID survivors. Here's a study just to highlight what's known to date about what these COVID survivors can see in the post-ICU, in the post-hospital setting. So this was evaluating 143 previously hospitalized patients in Italy, and this was 60 days after symptom onset that these patients were seen in clinic. And what you can see here is that 87% had at least one ongoing symptom, with dyspnea and fatigue being the two most commonly cited symptoms. But you can see that there's an array of other symptoms that people were endorsing. And so we make sure to really kind of hone in on the most common of these for each of our COVID survivors. And then what also is notable is that 44% of these people reported a worsened quality of life after coming down with COVID. Here's actually some data from our clinic and what we've seen in our COVID-19 survivors. And so of 70 previously hospitalized patients who we've seen at UCLA, and this was actually at a shorter time interval of follow-up of 26 days, you can see that dyspnea and fatigue, again, are the most common symptoms that people are endorsing. We've also interestingly picked up on a significant amount of neurologic symptoms, including neuropathy, also headache and dizziness. And so we make sure to screen for those in particular in our COVID survivor group. In terms of the rest of our assessment and counseling for these COVID survivors, again, it's not too different from what we do for our other post-ICU survivors, but we do have a few COVID-specific areas of education that we make sure to touch on with this group. We talk a lot about lung rehabilitation, just given how common the dyspnea and the fatigue can be. We also talk about health precautions in terms of kind of ongoing protection and whether there's anything they need to do in terms of adapting their rehabilitation regimen in the setting of COVID. We also make sure that the patients are aware about particular COVID studies, such as and other donations that are available, such as convalescent plasma donation, just to make sure that these survivors are aware of some of these other opportunities to feed back and help people who come after them. I wanted to close by just summarizing and highlighting some of the guiding principles that we've used to start our post-ICU clinic, since our clinic was started in February and is still relatively new. And also in case this will be beneficial for anyone else out there who's thinking about starting a post-ICU clinic at your institution. And so, first, the one thing we made sure was to kind of start small and first show success with a pilot cohort. And so we started with just 4 patients a week, and really making sure that we were able to provide quality care for those patients. We studied this group from the start just so that we could continue to improve our process and to assess it. We found some pretty striking results, such as the fact that actually 0% of our patients have required readmission, suggesting that our post-ICU clinic is actually quite useful and beneficial in terms of kind of reducing healthcare utilization thereafter. The second point, grow from what's already been planted, was something else we talked about a lot, just to make sure that we weren't reinventing the wheel. And so we talked with many other centers across the country, specifically Vanderbilt, to make sure that we were kind of modeling our clinic after something that had been shown to be successful elsewhere. And then within UCLA, there were a various assortment of clinics that we tried to kind of adapt and model ours after. There's an extensivist program that's for high healthcare utilizers. There was also actually a neuro ICU follow-up clinic that was already in existence where we talked with their directors a bunch to get their insight. And then the U-Breathe program, as you'll hear about soon, has been tremendously beneficial for us in terms of getting this off the ground. And then lastly, and probably most importantly, we've really recruited passion and made sure to find an enthusiastic group of multidisciplinary team members who are willing to start something from the ground up and innovate and kind of be flexible and creative in doing it. And with that, we've found significant benefits, and it's been extremely rewarding, I think, for all of us. So thank you all so much for your time. That's the end of our slides, and we will welcome any questions or comments now. Thank you very much.